So let's move on to question 11 here. A 20-year-old male presents to the clinic with 6-month history of diarrhea. So here we have chronic diarrhea with weight loss. He is booked for colonoscopy and biopsy of the terminal ileum. The exam show cobblestone appearance and crypt abscess on the pathology. What's most likely to know? This is most likely it's IBD. To be more specific, it's most likely Crohn's disease. So this is most likely it's a Crohn's disease. So question 12, a 6-year-old man visits the doctor with history of severe colic abdominal pain, vomiting, and constipation. So here we have colic abdominal pain, severe colic abdominal pain, vomiting, and constipation. So this is element of bowel obstruction. Past medical history unremarkable, with the exception of the laparotomy 6 years prior for the perforated duodenal ulcer. So we have history of laparotomy 6 years ago. There are no bowel sound in auscultation. So this is all consist with mechanical bowel obstruction. Based on the history, what is the most likely diagnosis? Is it acute pancreatitis, or it's gastric outlet obstruction, or it's large bowel obstruction, or it's low fiber diet, or it's small bowel obstruction? Most likely it's adhesional small bowel obstruction. It's adhesional small bowel obstruction. Adhesion is the cause of this small bowel obstruction. Question 13, 46-year-old female smoker with BMI of 30, who is the mother of 5 children, presents to the emergency department with severe epigastric and right upper quadrant pain with a radiation to the right shoulder tip. So the pain is mostly postprandial and aggravated by fatty food. She is febrile and temperature is 38 degrees Celsius and white cell count is 15 and CRB is 100. So they are all elevated. Amylase and liver function tests are within normal range. The examination, she is Murphy sign positive. Which of the following tests will confirm? This picture is typical picture, and this scenario is typical scenario for acute cholecystitis. So this lady, most likely she had acute cholecystitis. Which of the following tests will confirm the diagnosis? CT scan of the abdomen, erect chest X-ray, or magnetic resonance cholangiopancreatography, plain film of the abdomen, or ultrasound scan of the liver and gallbladder, or most likely it is ultrasound of the liver and gallbladder. This is this investigation will confirm the diagnosis. So question 14, a 3-month-old boy is brought to the general practitioner with intermittent projectile vomiting and difficult feeling. On examination, there is a palpable olive-shaped mass in the epigastrium. So we have palpable mass in the epigastrium. Arterial blood gas show hypocalemic, hypochloremic metabolic alkalosis. So here we have an infant, 3 months old. He has intermittent projectile vomiting, and this is very characteristic for one of the pathology in the differential diagnosis for this infant with vomiting. One of the top differential is going to be pyloric stenosis, and this age is very typical for pyloric stenosis, and this scenario or this symptom, intermittent projectile vomiting and difficulty with feeding, and very characteristic. Olive-shaped mass also, it's characteristic for them, and acid-base dysbalance, because they have refractory and recurrent vomiting, they will get hypocalemic, hypochloremic metabolic alkalosis because of the vomiting. What's the most likely diagnosis, or in the top of the differential? In the top of the differential, it's going to be here, CHIPS. It's called the CHIPS, congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. So most likely it's congenital pyloric stenosis here. So question 15, you have seen a 61-year-old gentleman. So 61-year gentleman in the emergency department who presented with episode of coffee ground vomiting. He was tachycardic, tachypneic, and febrile. You did the initial stabilization. He reported feeling unwell over the past weekend. He had passed few black tarry stools. So he has few black tarry stools, so which indicate element of upper GI bleeding. He has a mild abdominal tenderness. So he has mild abdominal tenderness, but no guarding. He is non-smoker and he used to drink a bottle of wine every other day, but he has abstained for the past 3 months. what is your impression here? So most likely this patient has most likely the most common cause of upper GI bleeding is peptic ulcer disease. So most likely this patient has peptic ulcer disease and had element of perforated peptic ulcer disease, because the patient has abdominal tenderness and the patient is tachycardic and tachyplic and febrile. So the patient has element of sepsis, and the source of sepsis most likely it's abdominal, and the cause most likely it's perforated peptic ulcer disease. So here the options we have: A, he has perforated peptic ulcer disease. This is, I think, the most likely. He has episode of gastroenteritis. Gastroenteritis unlikely to cause this severe state of abdominal tenderness and coffee ground vomiting and black tarry stool. So this is unlikely. He has bleeding from esophageal varices. There is no signs that indicate the patient has liver cirrhosis or alcoholic liver disease. So I think it's unlikely that the patient has bleeding from esophageal varices. Chronic angiospermia, it's unlikely here. On football disease as well, it's unlikely. So here the perforated peptic ulcer disease, I think, the most appropriate answer. So question 16, I am going to discuss this in the next video. Thanks for watching this discussion, and hope you the best for your preparation to your coming exam. See you in the next video.